Okay, what I'd like to do is show you our ICAT system, which is interactive communication assisted training for both staff and help educate patients. And I'm just going to take you through a few of these programs that we use as educational aids for patients so they can gain an understanding and visualize what they're going to be experiencing during their treatment. The first one we'll start off with is just putting braces on. So to put braces on, in our practice, we put them on one by one. So that involves, first of all, cleaning the teeth just like this, just like when you go to the dentist. Then we paint a glue on each tooth and we put the brace on.
You know what? Let's
And
do this one again.
okay,
That truck go by.
Motorcycle, yeah. Feels like the window's open, but it's not.
okay,
Okay.
So just go ahead and slide that back to the beginning.
okay.
You can,
All right.
not this one.
Okay, let me go back. Let's see.
Wherever you do.
Right here. I think I was right here. Okay. So first of all, what we do is we clean the teeth off just like when you go to the dentist. We then paint a glue on the tooth and apply the brace one at a time. Some practices put them on, they send a setup to a lab and then they put all the braces on at one time with a tray. They transfer it to the patients. But we like to analyze the distinctive morphology of each tooth. There's quite a bit of artwork to making sure that the brace is applied to individualize the tooth's morphology so that when the patient's treatment is completed, it's a more natural looking smile. So we still do it the doctor applies one brace at a time to each tooth, and then after about an hour or so, you'll have braces in all your teeth. The brace is really just a handle, so we then start to put the wires in, the brace being just a handle for each tooth, and it's the wires that straighten the teeth. So we start out with a thin wire, and these are all high-tech nickel titanium wires that just can't be distorted. They always rebound back to their straight original arch form shape. So you can see here the wire is kind of crooked like the teeth are, but after a month or so, the wire will kind of go back to its original shape and start to take the teeth with it. And then we remove that wire and we put a new wire in. And each month the wires get thicker and stiffer and thicker and stiffer and stronger and stiffer and thicker. And at the end of a few months, usually 3 or 4 months, 5, 6 months at the most, you'll have perfectly straight teeth, top and bottom. Once the teeth are straight, that's really the beginning of orthodontic treatment. So a lot of times you hear these claims of fast braces on this and that. Well, really, we all orthodontists do fast braces. Teeth are usually straight within 3 to 6 months. And straight teeth is really the beginning of orthodontic treatment, not the end. Once the teeth are straight, then you start working on correcting the bite. So this patient here you can see has an overbite due to a skeletal retrusion of the lower jaw. So the application of wearing rubber bands, applying rubber bands to the braces, puts the lower jaw in traction and helps the lower jaw grow faster and faster and faster. And in a period of 6 months or so, depending on how quickly the patient is growing, and that's why we try to wait until the patients hit their optimal adolescent growth rate, which is typically 12 for girls, 14 for boys. If you can time it right, you can get the jaw to grow slowly into place in a relatively short period of time. So usually another 6 months or so. So there are many cases that we spend 6 months to straighten the teeth and then 6 months to correct the bite. Once the bite has been corrected, the braces are removed, and we then make invisible retainers for all of our patients that are just applied to the teeth like that. And all of this is done through the use of digital scanners now. So we don't really take impressions anymore. We just scan your teeth, and then the lab sends us an appliance to place, usually within 24 hours. I just want to show you some of the typical malocclusions that we correct. I try to tell people that they kind of fall into 2 categories when you walk into an orthodontic office. Outies and innies, kind of like belly buttons. Outies, the front tooth protrude up forward due to a lack of muscular reciprocal pressure against the front teeth. So the teeth flare, usually weak lip muscles allow that to happen. And so those teeth are retracted like this through the use of braces. And this consultation program really lets us help the patient This program helps us allow the patient to visualize what they're going to experience in terms of the movement of their teeth. In ease here, you can see the teeth lean inward, and in those cases, the teeth are actually moved out to create a broader smile and develop the jaw so as to accommodate all the teeth. Back in the old days, cases like this where the teeth lean in, they would remove teeth thinking that there wasn't enough room for the teeth, but really it's the jaw that's too small. And if we can time our treatment properly during growth periods, we can help the jaw grow enough to accommodate the teeth like that. Many of our patients come in here and they have temporomandibular joint problems, and there's a little skit in here that I'm going to play, a little video that helps patient understand how there could be an incongruency in their bite and how that affects the jaw joint and typically will cause a dislocation of the jaw. So I'm going to go ahead and play this for you.
The bite, or how the teeth come together, is important because if the bite is off, problems may develop with the teeth and associated structures of the head and neck. While one would think the jaw would always close in a natural position, the jaw actually adjusts to the sensations from the teeth and bite. If the teeth are not in their proper positions, they can force the jaw out of its proper position, thus creating trauma to the associated structures. Even though the amount of jaw shift and microtrauma may be small and imperceptible, over time the accumulation of this stress and strain may eventually cause pain and other problems in the TMJ, teeth, ears, and muscles and tendons of the head and neck. These problems are more likely to occur to people who tend to clench or grind their teeth excessively.
Some of our patients have significant skeletal problems and they are no longer growing. They're adult patients, sometimes in their 20s, 30s, 40s. We've even treated 50 and 60-year-olds. The most common skeletal problem is a deficiency of the lower jaw, which causes an overbite. And once your growth has ceased in your late teens, the orthodontist can still straighten teeth. You can straighten teeth at any age, but we can't correct the mismatch of the jaw and the malocclusion or overbite. So we have to recruit the help of an oral surgeon, oral maxillofacial surgeon, where we apply braces to the teeth and straighten them first, and then the surgeon can go in and correct the skeletal problem intraorally by making incisions and lengthening the jaw, as in this case, to create a nice skeletal balance for this patient, correcting her overbite and enhancing her facial profile. The opposite type of problem, underbite with a strong lower jaw, basically the same type of procedure except bone is removed instead of added and the jaw is slid back into its proper position. There are other multitudes of imbalances. You can see here all these arrows. Basically, each of them signify a different type of bite problem. A very common one is what they call an open bite, where you bite, the back teeth hit, but because of a divergency in the growth pattern of the jaw, where the lower jaw has grown downward and the upper jaw has grown upward instead of growing parallel. So therefore, what's necessary is the surgeon will remove a wedge of bone in the upper jaw, thicker at the back, thin in the front, intrude the posterior portion, the back portion of the upper jaw as such, so that now when you bite flat and the teeth hit equally, and we're not torquing the temporomandibular joint out of position. I think that's pretty much it. There's one more in here, okay. Nope. I think I showed this. Didn't I show this? The rubber bands? I think I showed this. Right. Yeah, I think that's it. TMJ, surgery, how braces work. Oh, there's one more. Okay. Okay. A very typical problem that we frequently see is a transverse deficiency in the upper jaw. And that is usually associated with mouth breathing, allergies, asthma, where the midface is not functioning and you're not inflating the maxilla and the maxillary sinuses with air pressure. So what happens is the maxilla, the upper jaw, underdevelops, collapses, and is too narrow, and it looks like there's not really enough room for the teeth. So some practices remove teeth. Back in the old days, they used to take teeth out almost regularly on cases like this. But nowadays, with the expansion of the jaw, if we wait until all the permanent teeth come in, the jaw is actually a little bit larger, and we can apply an expander which will help develop the upper jaw and help the child grow into their teeth as such. And what appears to be crowding, where there's not enough room for the upper jaw and crowding in the lower jaw, essentially is really an underdevelopment of the upper jaw, where the upper jaw needs to be grown further and enhanced. And once that happens, then the lower teeth, if you notice, can go out to where they should be. So if we bring everything out, there actually is enough room for the teeth. And if I reverse this and essentially scrunch up the upper jaw, you can see that the lower teeth are going back in. So this patient really doesn't have crowding. They have an underdevelopment of both upper and lower jaws, or what they call a maxillary deficiency with the secondary mandibular accommodation, which means the lower jaw is accommodating to the deficient upper jaw.